at this point. So again, welcoming everybody to the Jousse Lecture. Today we have a great speaker, but before we start, we'd like to thank our sponsors for the lecture, the Neinstein Lawyers. On behalf of the team, I would like to thank Neinstein Lawyers for sponsoring the delicious lunch that those of you have at the hospital. Neinstein Lawyers has been a longtime supporter of Toronto Rehab, most recently funding the renovation of one of Lyndhurst's patient and family lounges, and also supporting Toronto Rehab's COVID fund. During these challenging times, our staff truly appreciate this kind gesture. At this time, I would like to present Michael Wolkowitz as an associate at Neinstein Lawyers to say a few words before we get started.
Thank you, Sue, for that introduction. On behalf of Neinstein Lawyers, I just wanted to thank everybody there for their hard work. We appreciate everything that you're doing for the community and for your patients, especially during this hard time. I don't want to take too much time because I'm sure everybody's anxious for the lecture to get started. So we just wanted to send those well wishes across. And, it's our pleasure to be able to help and give back any way we can. I'm going to pass it back to Sue now to introduce Dr. Harkema.
Thank you. So I'm going to introduce Dr. Harkema for all of you. I think many of you know who she is, but she certainly has a lot for us to tell you about. So Dr. Susan J. Harkema is a PhD professor, and she holds the Owsley B. Fraser Rehab Chair in Neurological Surgery and is the Associate Director of the Kentucky Spinal Cord Injury Research Center at the University of Louisville. Dr. Harkema also leads the KSCI-RC translational faculty within the Pediatric Neurorecovery, Adult Neurorecovery, and Epidural Stimulation programs. Over the last 27 years, her research has focused on neuroplasticity of spinal networks and recovery of function after spinal cord injury. She has maintained an NIH-funded research program since 1998 and has been funded by grants from the NINDS, NCRR, NIBIB, as well as the DoD, the Christopher and Dana Reeve Foundation, the Paralyzed Veterans Administration, Wings for Life, and the Craig H. Nielsen Foundation. During her career, she has published more than 110 scholarly articles or manuscripts and book chapters, delivered over 100 worldwide lectures and keynotes, and she has sat on numerous advisory boards and review panels. I can say that I know Dr. Harkema quite well. She was the external reviewer for my PhD thesis. And since that time, she has been a great mentor to me and actually a friend. So I'm really delighted to introduce her to you, all of you today. And her talk is titled Epidural Stimulation, Neuromodulation of Spinal Cord Injury. And just before we start, Dr. Harkema, would you like us to hold all questions until the end and have a bit of a moderated question and answer session? Or would you like people to put their hand up and ask on the way?
So I'm glad to have people put their hand up, but would someone be able to, in case I miss it, if someone can shout out, Sue,
Sure.
if you don't mind doing that, then I can kind of stop and answer the question. I'm happy to do that. I in many ways, I prefer that because this lecture is for you. And if there's something that you need to learn more about that I don't mention, I'm very happy to answer those questions. So if you guys are comfortable with that format, I'm fine with that.
Okay, that's how we'll do it then. Thank you.
Okay. Mm-hmm. Okay. Well, Sue, thank you for that really kind introduction. Probably and Milos, I see you there as well, but all of you, I can't believe it's 27 years or whatever it is. I feel like I'm still in my 20s maybe, but I know that Zoom is not doing me well, and I probably don't look that young, but it's been such an honor and privilege to have a career in the spinal cord injury community. Both from my colleagues, my incredible team that you're going to learn about what they've accomplished in this talk, and certainly those people living with spinal cord injury, their caregivers and their families. I think I've grown as a person just being in their presence. So as Sue mentioned, we have here at the Kentucky Spinal Cord Injury Research Center, we have an interdisciplinary university-wide collaborative program for spinal cord injury, and it's organized by amazing leaders, Claudia Angeli, Epidural Stimulation Program, Alex Ovechkin, our adult neuro recovery program, which is, quite frankly, everything that is not epidural stimulation. So we have lots of other studies that I won't really touch on, unfortunately, today, that look at other aspects of spinal cord injury that is not an implanted epidural device. And then, of course, Andrea Behrman, who many of you would know, the pediatric neuro recovery program. And we're organized, and my colleagues have built over the years is really a completely collaborative faculty that each has a scientific core, which would be considered their laboratory, in the areas which sadly pretty much constitute all the motor and physiology of a person that affect people with spinal cord injury. So we're organized by these cores that you can see over the right that you all recognize are a very unfortunate consequences of spinal cord injury that people suffer from their entire lives. So here is the incredible faculty that I have tremendous privilege to work with. You'll see some of their faces throughout the talk, but just a couple key things that I really want to emphasize in this row here is all the clinicians who really are incredible. They compose our research medical core. You can see they're from, again, all disciplines. And not only do they help us to medically screen our individuals, but they provide incredible insight to their areas of expertise. And they see those people in our program now as clinicians. And so we've really built this network of cardiologists, infectious disease people who now have a higher clientele of people with spinal cord injury. And I think we all can understand how that can be an overall benefit. So Dr. Boyachi and Wagers are our key clinicians who are also, Dr. Wagers is our primary study physician. And of course, you must all know Max, who is just a brilliant scientist as well. And so here's all the faculty. You'll see them mentioned throughout the talk. And as I said, it's just a tremendous privilege to have such a collaborative and integrated faculty. We also have some very close collaborators. We have other collaborators over the years, but these are the individuals from different institutions, and you probably recognize their names as well, who are closely working with us on our epidural stimulation projects. And then we have about 150, including faculty team. And so I would love to introduce you to each and every one of them, but these are really our research team leaders. So they run teams all the way from regulatory, surgical, data analysis, doing the training interventions. And so I really need to recognize them. And just please know there's stellar people under their leadership who contribute to the success of our program. So a way that I started thinking about this many years ago is, as we all know, that when a person has a spinal cord injury where the bone is broken, talking about traumatic, of course, in this case, and neurons die, and it's devastating. However, there's millions more neurons below the injury that are alive, viable, and I think I'll show you evidence today that under the right conditions can function. And this has really been the focus of my career, is really looking at how does the spinal circuitry function. And if you knew me way back when, it started with locomotion, but now it's expanded out to other physiological consequences. So what's our working theory? Well, first, that the human spinal circuitry is the final common pathway of all neural control of motor behavior. That's where we started. But now what we we're discovering is that it also integrates communication among physiological systems and movement. So it's important for homeostasis of the body between motor function and physiological systems. And if you step back and think about that makes sense. An example sometimes I give is that if you're about to run quickly, you're about to run, you don't want your heart to start pumping 5 or 6 steps later to increase that flow to your body to help you run. You want it to maybe even anticipate it. So a modulatory signal from the spinal cord, which knows it's about to take a step right to the heart, makes some theological sense. And I think what we're starting to discover is that there may be lots of control systems available in the spinal circuitry that in the instance of spinal cord injury, we can take advantage of. So, okay, so I'm focusing this talk on epidural stimulation. So let us give you the state of our epidural stimulation now. So to date, we have 38 individuals who have been implanted with a epidural stimulator in the lumbosacrospinal cord. And this has been over an 11-year period. Maybe it's 12 now. I mean, I haven't updated that. We have many projects. I won't touch on them all that involve implants for epidural stimulation. And so we're averaging about 1 month, pandemic willing, allowing across all the projects. We're now 27 males, 11 females. We have 37 of them are Asia A or B. We have 1 Asia C. So we've just now expanded out into incomplete populations. Here's the age. So you can see now that it spans a wide age range as well as years post-injury. Of course, as you all know, there's many medical events individuals have, which are also adverse events, but I think it's always important. I think it's important up front to kind of talk about those that are more serious, which we have had a hip fracture. We have had 1 infection that resulted in an explant, and we had 1 person who had pain with stimulation. To date, all have chose to keep the implant following their initial study. So we have 38 people in the world out in the home and community with the stimulator stimulating. So I want to talk a little bit about where we've evolved in the implant arena. And so I want to talk about something that's quite novel and is hopefully will be published soon. This has really been led by Max and Samina and Claudia. And Samina has done all the imaging reconstruction. Of course, Max does all the implants and Claudia runs the epidural program, but they really were the key people leading this evolution of this particular project. So as I said, our goal is to implant at the lumbosacrospinal cord. However, with the technology that we had in the beginning, you assume that the lumbosacrospinal cord is under T12. And so that's where you go and you implant, and then you use neurophysiology to try to confirm or to place it. Our goal is to place it, ideally we'd like to place it from L1 to S2, but it doesn't work because you have a finite length of the electrode. So we have to make decisions when we're in surgery. However, it turns out that there's a huge, tremendous, and we have this published, I believe it's in Brain, but there's a high variability, quite frankly, of where that lumbosacrospinal cord is under the vertebrae. So in fact, some people it can be under T11, or it can go to L1, L2, or in fact, some people have an additional bone in there that can kind of throw you off. So really trying to know exactly where that spinal cord we found is quite important. So what how have we done that now? What we're able to do is take high resolution MRI and I'm going to talk a little bit more detail and then reconstruct the spinal cord in the future. So this is actually also cut our surgery times at least 50%, because that first placement of the electrode is by MRI imaging over the spinal cord. So we implant in the same location, and however, here's how we're organized. So the way that we implant for a very specific design, and we have proof of principle studies now and prospective randomized efficacy studies, both that I think provide different types of evidence. So the proof of principle studies now that we have are motor control, which I think is more well known, for cardiovascular and respiratory, and for now bladder. So what does this mean as a proof of principle? Well, it means we implant a low number of people. 4 appears to be our magic number. So we start with 4, or groups of 4 or 8, and we do the same intervention. So it's a proof of principle. There's no randomization, and we're looking for hypothesis driven, although they're all hypothesis. This is really more scientifically, mechanistically driven. And then for the prospective randomized, you're all familiar with that. These are larger. So the one we have going right now is 36 individuals. They're randomized. It's a primary cardiovascular study. I won't be talking a lot about that, but this is how we're organized. So we have now ongoing studies in all these areas. And then when people finish their initial study, they can go into what we call intersystem studies. And so what we do, for example, I'll give you an example, you'll see some data from this, is, for example, let's imagine that you came in and you did a stepping study. You finished that study, you already have the implant in. Then we have studies to look, is there any indication that we can design epidural configurations that can improve these functions? And we do that already in implanted people to get the initial evidence. If we get evidence for that, then what we'll do is we'll design studies to come back and say, okay, now the risk of a surgery may balance out with the potential benefit of knowledge specifically for bladder. So this is, and then again, if you come in a bladder, you may go into motor and cardiovascular and respiratory. And one of the advantages of placing the electrode in the same place and looking for these effects is that if you think about this as a someday clinical intervention, you may be able to address multiple challenges that people with spinal cord injury have with one surgical implant. And so that's really our whole approach. This has been our approach for multiple years. So I don't want to go too much into detail, but I do want you to kind of get an understanding of the breadth of this and the projects that we have across this, and then also how many projects that we have in intersystem. And the other thing that I will tell you is that this intersystem also gives us a lot of knowledge and experience about how this might practically be moved into the home and community. And as I alluded to earlier, everyone has chosen to keep their stimulator in and use it. But of course, as you can imagine, we don't have follow-up funding. Nobody gives you funding for 15 years because to follow up someone. So part of the way that we've been able to help support these people is to design these intersystem studies and to learn more at the same time. And of course, they choose to be in the studies. It's not a requirement when we first implant them. Now, this I also kind of wanted to give everyone an idea of sort of the time breadth of our program. I know this is it looks confusing, but all I really want you to take home from this is that our first implant was in 2009. We started out very slowly. I think these first 4 are the ones that are discussed and quoted. We've done quite a few since then, but these were very risk. We tried to take the lowest risk individuals here. They were 2 years post-injury, very young, overall very healthy. But now, as what you're going to see is we've really broadened. We have individuals who are older in age, greater in time since injury, higher injuries that are motor complete. And what you can see here is this initial color is just color coded for their original study. And then what you can see is over time, people who have come back and participated in additional studies. And so really all I want you to take home from this is to see kind of how we're gathering our knowledge, and that we really have this cumulative stimulation experience across the years. And so now I guess 2009, that's over a decade that someone has been stimulating. So we have that safety data as well as that efficacy and follow-up data if things remain. Okay, so breadth of the program. Let me go back to what I started discussing in the beginning, was what I think is a really important advancement. And as I said, this is under publication, and we really are intent, and we're making steps to make this available to anyone who wants to do epidural stimulation, because we think it reduces surgery time. It helps you have higher selection specificity of where you want to put the electrode. So here's what we do. So we do, when I say high resolution, I don't necessarily mean it has to be a 3T. What it means is when you take the slices, well, part of it means that you take the slices, you don't put any space between them, and you have sufficient resolution that you can trace the nerve roots back. And so this is kind of the novel idea and technology of it. And so Samina is the one who is really the leader of this, and what she's able to do. So you can see, if you go down here, you can start seeing the nerve roots, and then you go back and you trace them back to the spinal cord. And so you can actually get a 3D reconstruction of the spinal cord with the spinal levels. And this has turned out to be important, not only for placement of the electrode, but for us understanding what has happened mechanistically, and has helped us understand in some cases why some people respond differently. So what you do then is you reconstruct the spinal cord, then you compare it with the X-ray, and then what we do is we're able to place that electrode on this 3D reconstruction for each individual. And so if I then decide to put my cathode here, I know I'm over L2 with quite specificity. So we do pre-surgery 3D reconstruction, and then in fact Samina's on call during the surgery, so we will take pictures and we'll say we put it here. She'll tell us back, okay, well here you're L2 to S4, or which one do you want, etc. So here's the reconstruction, and then what you can see here is she will give us predictions. So we have this in surgery, so the neurosurgeons know that if they place it here in the bone, this is where they should be in the spinal cord. And then here would be another example. So what she'll do ahead of time is she'll give us different placement selections. So she'll say, okay, if you want to go from L1 to L5, this is where you want to put it. If you want to go from L2 to S1, this is where you want to put it. If you want to go, etc. And so this is an example from this exact intervention. This is where Max and either Claudia or I'm not sure who was in surgery for this one, decided to go. And so it was L3, S3 is where this individual ended up. Now, just to let you know, you think, well, locomotion, boy, gosh, why wouldn't you go up higher? Well, it's turning out, and we're going to show you a little bit of data for bladder, that we like to be down here as well. So we can optimize our bladder function responses. So we make decisions, one, based on what the primary project is, and then two, and I kind of joke, you'll see April and Claudia. So Claudia does mostly motor, April does bladder. And so when I'm the one doing the surgery, I'm thinking, oh gosh, April on one shoulder and Claudia on the other. Claudia is saying, scoot it up a little, and April saying, make sure you keep it down. So these are just decisions we need to make. And we can already imagine that having more customized electrodes or longer electrodes, or et cetera, could be an advantage if we find out the evidence is sufficient to go into a clinical indication for higher numbers of people. So here's just another example. This is an L2S1 placement, and then L2 to L5. What I wanted to show here is what we do is we send these images back to Samina, and she really quickly with her program can tell us where we are. And again, that helps us make the decision. So at the end of the day, I think we ended up with a pretty good compromise where we started at L2, but we could reach S1. So that's where we ended up with this individual. Now, We also do neurophysiology to also confirm, so we don't just go by the imaging. As you know, there's going to be blurring around the edges, so it's not going to be exact. And there's some error in the exact reconstruction. So we also follow this up with, we do this in the surgery, and then also after they've recovered in great detail. But what you can see here, of course, which probably a lot of you are familiar with, is if we pick the cathode and anode here at L2, and then we look at the EMG recordings and we start increasing the intensity, we can see the relationship of the threshold and when they're coming on. And so that also gives us neurophysiological feedback of where we are. If we flip it, we see the opposite response. Now, as I mentioned before, the other aspect this helps us with is when, for example, if we're looking at cardiovascular stimulation, we know where the electrode is, and it's hard to see here, I apologize, but this black is where the cathode is. And as I'll tell you later, L3, L4 is where we get the cardiovascular responses. And so we can go right away, find those electrodes, and you can see here, no stim, they have really low blood pressure. With stimulation, they have stabilized blood pressure. And so it also helps us when we're selecting configurations, and has really cut down that time. Okay, so out of surgery, we're going to switch to motor. So I want to take you through a couple of our key points about what we've learned about locomotion. What you're going to see here is the design of each of these studies. So when we started our design here, we did 5 days a week of locomotor training, step training on the treadmill. We did not do any over ground because it wasn't safe at this point to take them over ground. But then we do the implant, and we would do 80 sessions of stand training, and then 80 sessions of step training. So the very first paper I'm going to just mention quick first, because this is sort of everything sort of in our path forward really evolved from the observations that we saw in this first individual. And that's why we really do feel very comfortable with this proof of principle approach before you go to a higher number of individuals, because you have a lot better control. And so we feel that you can get a lot of very important information that helps you then to plan your larger studies. So one of the key aspects of one of the key discoveries, which we will continue to share with everyone, is that really it was Rob who discovered this, but he's an Asia B. And what he did when we were doing some extensive mapping is he tried to move voluntarily. And when the stimulator was on, he was able to move voluntarily. What you see here is the data on the left. So this is during stimulation. But if you turn the stimulation off, he's not able to move. And you can see that clearly on all the no stimulation. So this is left leg flexion, left toe extension, left dorsiflexion. But I think the second important thing is this: when the stimulation's on, it is tonic. It is on all the time. We are not trying to target a flexor or an extensor. That is one way to stimulate. And in fact, there's another, of course, Gregor's group, they take that approach, which has been also successful. But it's really important, I think, to understand the differences in how you stimulate as we understand both mechanism and what might be potentially best for different types of individuals. But the key point here is that although the stimulation is on during the time period, you can see the bursts are not on the entire time that the stimulation's on. So we really design our configurations to be sub-motor threshold and let intent drive the movement. So what you can see here is I think, a reasonable EMG pattern for someone who might generate that without an injury. And so what we're really doing is modulating the state of excitability of the circuitry to accept afferent information and information from the brain. We call it intentional. Of course, it's well known as voluntary. And you get complex motor patterns with a tonic, consistent stimulation pattern. So those of you who've heard me lecture before, at the time, I thought, wow, look, it's Asia B. We must have reorganized the sensory fibers, become motor, blah, blah, blah. We can prove this. This will be the greatest paper of all time of my career. I'm going to show this. Maybe it'll get in Science. We're going to get an Asia A and show that even if we stimulate them with epidural stimulation, they won't be able to move. And of course, you know, that's not what happened. I didn't get my Science paper. This Asia A moved voluntarily as well. And not only that, the first time we tried. So with our first individual, he discovered it way into our training paradigm. So this was even before, this was the first time we stimulated them with epidural stimulation. And again, what you can see is that there's the complex motor patterns. These are multiple people now, so we did try it again and again. And just some of the key aspects of it. Without stimulation, there is no movement. With stimulation, so if you see here, the stimulation is consistently on, but it's when he intends to move his leg that he moves. And I think that's one of a really important point that I'm not sure is always clear. The other thing is we do know that this isn't all happening at the spinal cord. The brain is involved because we do a tone above the lesion and they can match the tone. Or we have a sine wave and we say, hey, small, medium, large, and not perfectly, but they can grade the force of that contraction as well. So we certainly know there's communication across the injury, even in someone who is diagnosed as Asia A or clinically complete. So to date, this is 36 out of 36. We do have 38 now. But to date, every individual who was diagnosed with a clinically motor complete, when we have attempted voluntary movement, has been able to move at least one joint. Now, everyone cannot move all 6 joints that we test. For this design, we test hip, a leg flexion, which we call hip flexion, ankle and toe. And what this shows you is, you know, this is their Asia levels here. So it doesn't appear to be related to their injury level, nor if you call A and B the severity of level. But this shows you everyone was able to move at least one joint. So we have 3 people who could move one. And then out here are the number of people who can move all 6. And then there's some, it's in between. And this is on initial. And we can't find yet a correlation to level of injury or whether they're Asia A or Asia B. I think and also not time since injury either. So this is over here, number of joints moved versus time since injury. And I think the most obvious example, although an N of 1 is not your take home forever evidence, but we did have someone who was 38 and a half years post-injury who was able to move all 6 joints after 38 years of not being able to move them, to move all 6 joints the first time we attempted. So I think as important as the Asia scale is, and this idea of clinically complete, that it informs and gives us a lot of knowledge, I think we may want to rethink what that means, both in our research as well as clinically, that even someone who has an Asia A injury for almost 40 years later, with the right knowledge and the right technology, they can move again voluntarily. Okay, so now I'm going to move on to stand and step training. So and give you some insight to some of our results there. So to give you a little history, we started out with the hypothesis of just locomotion. We weren't thinking a lot about standing, but our first individual, and here he is, the first day we put him up on the treadmill, he stood independently with full body weight support. He did have the harness, so not balance. And so we redesigned our study because we thought, okay, this is something that might translate into something that people can use now in their home and community life. So we changed our design here, as you may know. And what we found with our first 8 individuals in these proof of principle studies, that they were all able to stand independently with stand training to some degree. Not everyone to the same degree, but they were able to stand, and some indefinitely, and even with very little balance assist. So I just showed you A's. These are individuals with the A, but this is also the result if you had an Asia B as well. And here again, you can see without stimulation, they're not able to stand. Again, this is tonic stimulation. You can see standing EMG activity. Now, I will say these individuals generate much more EMG activity than we would if we stood, for them to be independent. So it's not like before injury, but it does provide them with independence. And there's modulation. So if they shift or shift their weight, you're going to see modulation in the EMG in that response without changing the stimulation configuration. Okay, so here I already mentioned it's 8 out of 8 independent standing that they were actually able to take home and continue on using in their lives. Okay, so I think the overground walking and a chronic motor completes is I want to touch on some of the key points here. So a couple points that I think are really important is here you can see the individual on the treadmill. You can see at this particular stage, there's some independence, but you needed still to have some assistance to continue the stepping. But then over time, the individual was able to step one leg independently with very little assistance, and then eventually was able to step independently on the treadmill and to carry that over ground. And so he's a high cervical Asia B here, also able to stand independently. Now, one of the things I want to point out here is this group of 4 that we published in the New England Journal of Medicine, we changed how we were training. So remember, we did stand training for 80 sessions, and then we did step training. And none of those 4 were able to step both legs independently. So we took a step back and we said to ourselves, gosh, what happened to the cats when you trained them to stand? They had learned to step, cats who were transected, they had learned, we should know this, they had learned to step. When they were trained to stand, they lost their ability to step. So was there something about training people to stand first that may have influenced the learning of the ability to step? So this group of people, we trained both. So we asked the question, how smart is the human spinal cord? Could the human spinal cord learn to stand and step at the same time? And that's here, it turns out they could. So they would stand in the morning, step in the afternoon, step in the morning, stand in the afternoon, so this is the other individual who was able to walk over ground and as well. And so you have a cervical and a thoracic. So it's an N2, I understand that, but that doesn't seem to influence it. But also other motor abilities were realized as well. So with the stimulator on, he's I'm going to say, I think he's C4, C5. I may have it wrong, but he's not C7, C8 for sure. But the point being is with the stimulator on, here's with without, here's with on, and so his trunk, his ability to stand, and interestingly, which I won't get into, also his arms and fingers do better when the stimulator's on as well. Okay, so another important point is we did this paradigm with 4 people. 2 were able to walk over ground, 2 were not. Okay, so I want to show you those who weren't. And something that I think is important about a mechanistic, and I think also might be a technology limitation, possibly, but we don't know until the technology is improved. But what you can see here is this individual could step one leg or the other, but not the 2 legs together, is basically the bottom line point of this. And this was dependent on their intent, so, and the configuration. So one configuration was better for the left leg to step independently, another was for the right, but he also had to be thinking about that leg as well. So this integrated intent, right state of excitability of the spinal cord, right afferent information, you got to get it all right, all at the same time for this effect. So we do feel that if we had better technology, maybe things would be different, but we don't know that. It could be that of Asia A's and B's, maybe only 50% will have the capacity to walk over ground again. And that's a big jump, but we don't know. Those are questions that are still there. But I think we have evidence. Sorry, I'm going to switch quickly to some. I want to tell you two other things, but I think what we have learned is that how you train is important, how you set the configurations is important, and also the timing of that. And so I think it's really important to understand that as you design your own studies, if this is what you're interested in, is to really learn, hopefully learn from that type of information. Okay, so I'm going to switch quickly to cardiovascular function. And again, as I said, it's just been such an honor and privilege to work with people in the spinal cord injury community, and probably our most important discoveries have come from them, not from us. So one of our first 4 individuals, we were having difficulty keeping him upright because of his severe cardiovascular dysfunction, but we had noticed that during our mapping that there were certain configurations that would raise blood pressure but not give us motor activation. So from my scientific mind, I said for the locomotion one, well, gosh, if we just flipped over and let him keep his blood pressure up in between, and then it wouldn't affect the study because it's not activating the motor. And then he said to me, wow, if I could use this at home, it would change my life. I could go out to eat with my wife and not have to tilt my chair back. I could get dressed faster. So we went to the FDA. We said, what do you think? Can we do it? And that was how understanding lumbosacral spinal cord epidural stimulation could modulate blood pressure. So let me give you just a little bit of data from that. So what you'll see here, so again, we did a proof of principle study. I'm going to talk a little bit while this is going on, but what you're going to see here, so here's the blood pressure monitor. You can see 87 over 50. She is starting to increase the stimulation. So, and you can see we also have a phenopress, so we can look at the beat to beat. That's the data that you have here. And so here's stim off. And you can see, as you all know who work with people with spinal cord injury, they have very unstable blood pressure. They can be 80 and they can be 100 and then they can be 150 and so they can be very unstable. So you see a bit of a varied baseline here, which is not unusual. But when we start ramping up, we ramp up, and you can start here is when we start ramping up. We selected a target of 110 to 120 that we wanted to keep that in. Here's the heart rate. Now we target systolic. Now what you can see in the video, you just saw the time it took for us to get it to 109, from 80 something to 109. And this is the data here. And then as long as the stimulator's on, we need to modulate amplitude, but we're able to keep it within a stable target range. So as I said, our proof of principle studies, we had 4 individuals. And what I want you to take home from this slide here is, if you can focus on this graph here, is that we were able to achieve this in all 4 individuals. But the configuration is very important. So kind of the take home here is it's not just stimulation alone, and it's also not stimulation that elicits contractions in muscles, which of course we know could raise the blood pressure. In fact, we design it so they don't activate their muscles. And so what you can see is here's a configuration that works, and it doesn't, if you look here, it's not dramatically different, but it is very different. I mean, it does make a big difference in whether you can regulate the blood pressure. So 2 take-home messages here, that there are specific configurations, and once you find that configuration, you can keep the blood pressure very stable. And we now know even up to 6 hours. And this is just showing the averages, so that, but I won't go into that. And then the last thing I want to tell you about this is this also is able to alleviate orthostatic hypertension as well. So this is here, it's a sit-up test. We now do it with a tilt test, and it also, even if you go full upright, we get similar results. but here's from one individual, and what you can see. So here's the blood pressure and the blood pressure and heart rate. So here's blood pressure. You sit up, of course, and their blood pressure goes down dramatically. The heart rate goes up, but it's not sufficient for them to maintain a normal blood pressure. Now, be clear here, this is not necessarily in a normal range, because of course they very rarely live in normal ranges. So we're taking it from whatever their blood pressure was and drop here. Now, before intervention, what we find is we can maintain that even when we do a postural stress. What was surprising to us also was after 80 sessions of training with cardiovascular, this was for 2 hours a day. We're now doing it for 6 hours a day. Even without stimulation, they were able to maintain their blood pressure. Now, not to the same degree. So I don't want you to be misled. This in the sense is that with stimulation was better, but they could maintain their blood pressure here. Now, this is in the, with stimulation, we keep it in the normal range. Here, it's not in a normal range, but it doesn't drop significantly. Hopefully that's not confusing, but I don't want to give you the impression that if you stimulate people that they eventually come off the stimulator to keep stable blood pressure. So, okay. So, this number has gone up quite since then, but we, again, like the motor activity, once we have the right configuration, we are able to stabilize blood pressure, at least initially in each individual. Okay, now really quickly, I just want to touch on bladder. And so this is work by, I'm sorry, I don't have her picture, but it's April Harity is our scientific director of the Bladder Core. You saw her earlier, but also Charles Hubscher is another investigator leading these studies. And just a couple points I want to take home from this. So as you all know, bladder dysfunction is quite difficult and is probably one of the biggest detriments to individuals' quality of life, not just because they can't void, but because of what happens when their detrusor pressure will go up, so will their blood pressure. So they have lots of high and dangerously high blood pressures. And so you can see this as you record detrusor pressure, EMG. Under the, again, I want to emphasize this has really been led by April. We can find configurations that what we call our integrated inner system, that here you can see also their capacity was only 171 in this cystometry, but with the right configuration, we can expand that capacity. Here it's 484. We get detrusor activity, or sphincter activity, and we can keep the blood pressure low. So we learned that from our blood pressure. We can bring those configurations in together and do both those. And in addition to that, there are, of course, there's reflex, we call that leaking. Voluntary void, again, remember this is tonic stimulation. This is the person intending to void. So that's the difference between the leak and intention to void. So without stimulation, there's no voiding efficiency. Now this is a very small voiding efficiency, but what you can see here in this particular configuration, when they attempted, they did not, they attempted again, and then they were able to void. This is just a summary of multiple mappings here where they're leaking, but here they're able to voluntarily void, and it shows you the efficiency. So again, it's not back to pre-injury, but we're able to move the needle, if you will. Okay, and the last thing I want to just quickly talk about, I alluded to, we need some technology. Definitely, for this to be viable in the home and community, if we show the appropriate efficacy data, there's going to have to be technology advancement. So I just wanted to give you sort of where we are. This is not where we are. This is where we imagine to be, okay? So this is a Medtronic Intellis stimulator. We have developed some customized software in collaboration with Kessler Foundation, Johns Hopkins Applied Physics Laboratory, and Medtronic to develop specialized SCI. So we're using the same hardware, but now we're developing new software. And we have an API, which we're calling StimXS now, where we can build modules to bring in sensor data. And then, of course, the long-term vision is to create artificial intelligence learning algorithms. So really in the home and community, this is much automated for individuals. So that's where we're imagining to go. This is where we are. So we just had the first release of what those of you who are clinicians or are aware of pain stimulators or stimulators, this would be like your clinical programmer and this would be your patient programmer. So, but now it's on a tablet. Both software packages are here, which is nice because we can shift back and forth for the specific things. So one of the big things is we get continuous stimulation when we switch programs or most known as groups. That's critically important. I won't go into the details. We now have higher resolution for more frequencies, and we can have as many programs as we can fit on the table. So on the tablet. So we can have over 1,000 different programs. If you're familiar with current stimulators, you don't have an infinite number of programs available. Also, I don't think I have a picture of it, but we've designed the interface so that those who have arm and hand disability now can control it themselves instead of relying on a caregiver. So anyway, those are kind of the key things. And just to show you how this has helped in the community, this is a C4 Asia A. And with this new release 1, she was not able to do this before. And I won't go into the details why it's so important, why it was, but now she was able to do this, and she's able to take it out into her community where she's at a community fitness and wellness center. The other is, again, being able to integrate this into her life. She's able to, now again, remember this is tonic stimulation, but now we're able to switch programs very quickly. So she's able to do these leg lifts. And then people say, well, is she still a C4 Asia A? Well, is the stimulator on or is it off? If it's off, then yes, she's still a C4 Asia A. If it's on, I don't know how we would do the Asia in that case, but I'm going to leave you to decide. Okay, so let me go on. Oops, here we go. So in summary, I think that kind of you guys can read this, but the one thing I really want to say is rehabilitation is a treatment. It is critically important. We need to invest in it. Everything that we do is coupled and driven by rehabilitation. So this is my little soapbox that everyone, insurance companies, scientists, we all need to invest in rehab. And I just want to end with giving you a little insight to those who've made this happen.
Complete paralysis is not a thing. There's something here we didn't really understand.
Hey, Susie, check it out. Look at my toe. Up, down, stop everything. Stop everything right now.
I eloquently said, holy shit. And, I'll never live that down again.
This is, how are you doing this? Close your eyes, do it again.
Fast forward now, we have over 20 people who were supposed to be motor paralyzed, and all of them have moved voluntarily with the epidural stimulator.
I think it's been in the past few years that we really start to understand the true impact of epidural stimulation.
Being paralyzed is more than just being confined to a wheelchair.
They may not die from the accident, but they're always sick. If you can do something that incrementally changes their lives, you are not only changing their lives, but you're changing their entire family's life. And you're also changing the cost to the healthcare system.
Looks good. Pressure stable, 16 over 64.
Dude, you made my day. Thank you. You made my life. Since being implanted with a stimulator, my blood pressure is regulated, infections are better.
I can't tell you the last time I went to a doctor's office for any medical issue relating to paralysis or being in a wheelchair.
Every morning that I wake up, my body feels warm. I feel my legs humming, I feel my feet
And then all of a sudden, 2 weeks later, that twinge turned into a full movement. And, you know, that movement was a couple movements.
Incremental small steps. And that's how we train.
I stood at my wedding, being able to do that, to have the first dance with her and my mom. That was huge.
What a treat it is to feel alive.
Before I was implanted, I mean, honestly, our goal was to stay alive for the day. Now I stand. Singing is, that's me, that's my everything. Now that I've been implanted, I can push out my notes now. I go out by myself and I look across the water. But since I've come on home, well, my body's been a mess. And I miss your ginger hair and the way you like to dress. Won't you come on over? Why don't you come on over, Valerie?
Oh, sorry. Oh, okay.
Thank you, Dr. Harkema. That was an excellent talk. I think we all very much enjoyed it, but I think I'd like to extend my gratitude for how much work you've done pioneering epidural stimulation over the last 20 years. So I think all of us as scientists and clinicians and people in the community of SEI are incredibly grateful for the work that you and your team have done. On that note, I'm going to open it up to the attendees of the talks to please, if you want to raise your hand or just unmute and ask a question or comment.
Maybe I'll start with a question, Dr. Harkema. I am very curious, you were talking about next steps and the future and just putting all that complexity in. Do you see that as something that, as a 5-year goal or a 10-year goal? How far into the future are you thinking that this might actually happen?
Well, if it was up to me, maybe I could give you a good answer. But, in all seriousness, of course, there's so many stakeholders that have to make certain choices for that to happen. Really what we have in our control is to just keep providing evidence. And then other stakeholders are going to have to take that evidence and decide when, when they think that this is, they want to move forward. And who are those stakeholders? Well, first of all, it's the stimulation companies, right? Because of course we can't, I can't, I'm just going to say, I can't build a stimulator and, but there's many companies out there that are working towards that. And that's going to be an important step, but they're the ones that, to go to the FDA and get an implantable device cleared is tens of millions of dollars, right? So they're going to have to make that decision that business model is works for them. So that's one. Then the second, of course, is that clinicians are going to, they've been caring for these individuals their entire lives, and they've got to decide if the risk of a surgery or what, if this is going to be worthwhile in their practice to do over what they're doing now, right? So the clinician decision is going to be critically important. And then, of course, my least favorite, but most probably critical, is the people who are going to pay for it, right? The insurers. So you're going to have to go and get insurance. And it's very interesting because I get asked this question all the time, like, so is this study are you going to get FDA approval? And I always say, well, I wish I had that breadth of knowledge and degrees, but I can't make any of those decisions. The decisions that I can make is to continue to study, provide evidence, and then work with these stakeholders to give them the information they need if the evidence is sufficient to go forward. So I wish I could give you an answer, but I can tell you this team here is really dedicated to trying to move things forward. And the thing is I would say that just to give you an example, we would suggest, because we hear from those in our program, that their lives are changed simply by stabilizing their blood pressure. And those with the most severe instabilities, it has really changed their lives because they can eat and talk at the same time. They can get through a day without passing out. They can be away from it. So we've had many people move out of their parents' homes because they're not afraid of really, you know, I hate to say the word out loud, but dying because they could pass out and have someone to revive them. So I think we have to take this, it's not a revolution, it's an evolution, is to kind of identify those things that maybe we don't have any treatment for, which is blood pressure, right? I mean, and start translating those and continuing to learn. I think we have so much to learn. I mean, we're scratching the surface of this understanding. So took a long time not to answer your question, but hopefully I've convinced you that I did it in good faith.
Okay, I'm going to pass it on to Hope. Hope has her hand up, so if you want to go ahead and ask one question for.
Good afternoon, Dr. Harkema. I really enjoyed your talk, especially learning about the reasoning behind many of your different decisions. And in this talk, you mentioned how training is really important. And in previous studies, you found that epidural stimulation paired with stand training helped with volitional voiding. So continuing on the topic of bowel and bladder function, do you plan to pair locomotor or stand training with epidural stimulation to affect bladder function, or do you plan to shift the focus onto other exercises like pelvic floor, for example?
Okay. Was that one question or 10? So no, it's a great question. Thank you very much for that question. Okay, so let me ask what do we do going forward? So let me kind of tell you our overall plan. So we think it's important to get very specific information on one thing, right? Because that's stronger evidence, for example. And you did mention work. So when we did epidural stimulation with locomotor training, we got feedback on improved bladder function, right? But now when we do bladder function for bladder function, we do it in that context. Okay, so we have different configurations. And so just let me give you one scenario. So we'll take a person who has low blood pressure. So they have a blood pressure configuration. They're going through their day. Their bladder's filling up. It's time to void. They switch their program from to bladder capacity to let their bladder fill a little more. Then they switch to void with a cardiovascular component. They void. They go back to cardiovascular function. Now, so this is our vision. So when I always think about the vision, my vision is they can sit up, they can stand up, they can walk to the restroom, they can sit down, they can void, and then, okay, I'm going to leave it there, but you get the idea. But each of those will need to get to that point from where they are. They're going to need specific configurations and specific types of training to optimize that. So going back to your question, do you plan to do locomotor training with bladder stimulation? At least from our knowledge base, that's not how you would do it. When you're stepping, you use a stepping configuration. When you're voiding, you're going to use a voiding configuration. And so that's why this development of the technology is so important for it to really be useful in the home community. So hopefully I answered your question. But just to let you know, we are continuing on, and I don't know if you noticed that, but we are continuing on, of course, with Locomotion. Claudia, that's now her, she's the leader of that, the motor and the locomotion. And as you can already, as you might have noticed, that C is in a stepping trial. So we're doing, again, we have that, you start, but then you can go in this integration of systems and we can add on these other aspects and do them together in an integrated way.
Okay. Thank you. I think Dr. Popovich has a question.
Thanks, Susan.
Hi, it's so nice to see you.
Good to see you, Susan.
I wish I was there. I wish you could see
me too. Fantastic lecture. Thank you for this. This is really great. And thank you for being so kind to spend time with us and show us what you've been doing. I have a question which kind of goes after Hope's question. You said for all these different conditions, you have to have different configuration of the electrodes and parameters. So maybe I missed it during lecture, so I apologize if I'm asking something silly. So how do you shop for those configurations? Because you have a lot of electrodes and you have different conditions, and how that works, and how do you pair training and the parameter selection, and how long does that take actually?
Okay, so okay, great question. And we are again, reviewers willing. I'm not begging you all. No, I'm just kidding. Reviewers willing. Hopefully this will be published soon. But we are about to publish what we call our mapping manuscript. Okay, so I'm going to give you a brief nutshell summary of that manuscript and how we do it. Okay, so we start with we start with the 3D reconstruction, as I alluded to in the beginning. Okay, so we know where we are in the spinal cord, and then we do what we call spatial temporal mapping, and that's something that you've seen in the literature a lot. Look, Dr. Dimitrijevic and Karen Manassian did it way in Yuri, of course. They did it in the early days, where you just walk yourself down the electrode and you do, 0.3 hertz or 2 hertz stimulation, and you see the evoked response and you know where you are. And then you do frequency response curves, right? Because we can, and you start seeing, you start seeing oscillations, right? That's been reported by others even before us. And so you can, I call it playing the spinal cord. Okay, which note is this? Oh, that's C sharp. Oh, if I put C and D together, this is what happens. So we do that, and we call it spatial temporal because we spatially go up and down, rostally caudally. We change amplitudes at a given frequency, and we change frequencies at a given amplitude. Now, at the same time, so when we see oscillatory behavior, that gives us an idea where we want to start when we do what's called functional mapping for walking, right? When we see, so if we want to do voluntary movement, we look at these maps that we create, and we look for where the lowest threshold is for that muscle group, right? And that tells us where we want to go on the electrode. So we do, and what we're also doing, and I alluded to earlier, is we're measuring blood pressure, and we get blood pressure maps. So we now we're with other data, we're pretty confident that L3, L4 is the important area, but and we know it from, but in the olden days, we would look only at these maps and see where we got blood pressure and not motor activation. Okay, so that's step one. So we have we have 3D reconstruction, we have the spatial temporal mapping. Then we go off and we branch off and we do mapping for each thing: standing, voluntary, cardiovascular, bladder, and everyone, but we feed off each other. So for example, if Claudia does the voluntary mapping first, I know where in the spinal cord she's getting ankle movement. So let's imagine that I find something that raises blood pressure, but I'm getting ankle movement. I can go right in and put anodes there and stop that ankle movement. So we learn from each mapping. So for the bladder mapping, I'll just give you one other example. Bladder mapping is going to look at where we want to target the spinal cord, which from the image, spatial temporal mapping, but takes the cardiovascular config and adds it into their cohort as well. So they there. So that's really, and we've got a paper, under review. And again, I'm not soliciting, but we have a paper under review that really goes through all these steps in more detail. So how long does it take? Well, it takes longer if you're me than if you're Claudia. No, I'm just kidding. Because she's so brilliant. No, I mean, so the spatial temporal mapping, so I think those are two different questions. If you're doing it scientifically, or what do you need to do clinically? And usually people want to know, how long is it going to take clinically? And so we don't know for sure that answer, but we're starting to build some models like that. So I don't know which way you're asking, but we do two 3-hour spatial temporal mapping, but that's also to answer questions about the circuitry of the spinal cord. You don't need that much in order to move on to your functional mapping. So so I think that you could do 1 day of spatial temporal mapping. Now, one limitation is you can't just do all the mapping in 1 day, because as you all know, as neuroscientists, that stimulating is going to change the state of the spinal cord. So to do initial mapping, you can't do them right after each other. So then again, with voluntary, I mean, I think each one of these could take 1 to 2 sessions. So now we are pretty consistent in getting the cardiovascular configuration, for example. This wasn't true in the beginning on the first day. But we do it multiple days to confirm, to do, et cetera, but we can find that configuration within 2 hours and really less. We wait 2 hours to make sure it's stable.
That's pretty good.
Yeah, so that's pretty good. Voluntary, I would say each one is within an hour or two if you have the history and the experience and the knowledge of what you need to do. So one of the things that we are doing that we also want to make available, not only those configurations that work, but those configurations that don't work. So if you saw in that picture, we call it global datacron. We have saved all of our configurations with notes. And so why it worked, why it didn't work. And we're really working hard to create that data set for other people's use. And we might say the ones that don't work might be more valuable. Don't go do the ones we did already that don't work. Skip those and go to the ones, you know, start from where we are. So I think that it's going to be important to have a global database that all people can access. And we've also designed it knowing that people are going to use different stimulators and different electrodes. So we try to convert that into that understanding. Now, once spinal cord injury specialized devices come out, we can modify our database to target those and try to help people find the right configurations.
Excellent. Thank you so much.
Okay.
Thank you
Hopefully
for the lecture. It was great. That's great. It's great. Thank you.
Okay. I don't see any other questions, but I also don't see, we also don't have any more time. So we've got to, but I did want to just let everybody know that, oh wait, there might be a question. There's a question in the chat box real quick. What is the basis for the stim configuration, and did you target? Okay, similar question. I think that was just answered.
Okay.
I mean, that was a great lecture. Thank you, Dr. Harkema. Hopefully we'll get to see you in person in the near future. One of our conferences. We'll keep our fingers crossed.
Yeah.
But in the meantime, it was a great lecture. Thank you.
Thank you all so much.
Yes. And I wanted to let everybody know that the next Jousse lecture is Adam Villanosi, and he will be talking about the SCI Biobank in Canada. And I don't have a date, but it's the 3rd Thursday of the next month. Okay. Thanks, everybody.
All right.
Bye.
Take care, guys.